point. Good evening, everybody. Today, what we'll be discussing is about the diagnosis and management of patent ductus arteriosus. I'm Dr. Prashant. I'm a consultant in pediatric cardiology at Kokilaben Ambani Hospital. So patent ductus arteriosus is a common cardiovascular abnormality in the preterm neonates with a reported incidence of as high as 60% in low birth weight newborns less than 28 weeks gestation. There is little evidence of consistent effect of the treatment of PDA on major preterm morbidities, and aggressive attempts to close the PDA is now being questioned. So morphogenesis, PDA is a vascular connection between the proximal descending aorta and the main pulmonary artery near the origin of the left pulmonary artery. I think all of us are aware of this. During the fetal life, it diverts the oxygenated blood from the pulmonary artery into the aorta, bypassing the lungs. There are various factors which help to keep the PDA open in the fetal life, and the sensitivity of the PDA to each of these changes as the gestational age changes. So exposure to low partial oxygen, circulating a local prostaglandin and nitric and local nitric oxide production. So if you see the fetal life, the PDA in the preterm, which is less than 28 weeks, it is less sensitive to oxygen. And as and it is more sensitive to vasodilators such as prostaglandin and nitric oxide. And as the gestational age increases, the sensitivity of the PDA to close in presence of high partial pressure of oxygen becomes high. So what induces the closure of PDA after birth is increase in the PaO2 and decrease in circulatory vasodilators such as PGE2 and PGI1, for which placenta is a major source. Both these factors cause this depolarization, calcium entry, and ductal constriction. As we all know, the functional closure of ductus occurs early, within the first 48 to 72 hours. The actual anatomical closure might take long time, but what we are worried about is the functional closure of the PDA. So what is different in the preterm baby? So in preterm baby, there is low sensitivity of the ductus to oxygen. As we said, in a baby who is less than 28 weeks, the sensitivity of the ductus to oxygen, even when it is a fetus, is less. There is increased sensitivity to vasodilators like nitric oxide and PGE2. And what are the risk factors which are associated with persistent ductus in the postnatal period? One is a birth weight which is less than 1.5 kilos, hyaline membrane disease, IUGR, perinatal stress, increased fluid intake in the first week of life. So what are the pathological consequences of patent ductus? The reason why we are discussing predominantly preterm is the medical management of ductus is usually done in a preterm baby. Once a baby is more than 2 to 3 months of age, we are more concerned about closure of the PDA. So if it doesn't close in the neonatal life, it usually doesn't close in the later in life. So the focus of this talk is basically going to be medical management of a neonatal patent ductus arteriosus. So what does a patent ductus arteriosus do in a neonate? It decreases the splanchnic and the renal blood flow. It causes congestive cardiac failure. It increases the LA and LV volume overload, and it thus causes congestive cardiac failure. It can lead to pulmonary hemorrhage, increased ventilator requirement, chronic lung disease, intraventricular hemorrhage, NEC, and finally death. So how do you diagnose that a baby or a preterm baby has a PDA? So as we all know, the typical signs like a continuous murmur or it's not going to be present in a preterm baby. So what is present is basically an increased pulse volume, the baby having tachycardia, a low mean BP, hyperdynamic precordium. Systolic murmur, as we see, is coming low on the list because the murmur is usually because of the flow across the mitral valve and the aortic valve. X-ray might sometimes get cardiomegaly, and there might be sometimes an evidence of increased pulmonary blood flow. Again, this is a little rare in a preterm baby. If you have to catch the PDA, it has to be caught early and then closed early. So how do we diagnose PDA in the newborn is basically by using an echocardiogram. So if there is a clinical suspicion of of PDA, as I mentioned, if the baby has got tachycardia, if the baby has got signs of congestive cardiac failure, if the baby has got an unexplained murmur, PDA will be, or if the baby has a requirement, echo session has got a PDA. As we all know, echocardiography is the gold standard in directly assessment of the PDA, in the assessment of the PDA, and to know whether we have to close the PDA or no. So we can see that we can assess the PDA, the size of the PDA, the shunt across the flow, and also we can indirectly assess what is the QPQS in this baby. So first of all is how to diagnose and how much is the PDA size. And if you see, it depends on where we measure, whether we measure at the aortic end or whether we measure at the pulmonary end. And for all practical purposes, the PDA has to be measured at the narrowest diameter, which is usually at the pulmonary end. So if you measure over here, this PDA was coming to somewhere around 2.2 millimeters, but if you measure at the aortic end, it's coming around 4 millimeters. So always measure the PDA at the pulmonary end. Then seeing the shunt pattern. So if you see this shunt pattern, what do you see in this shunt pattern? There is, so if you put a pulse wave Doppler across the PDA, whatever you get above it is the red flow, that's a left to right flow, and below it is a right to left flow. So what do you think about, what does anybody think about this shunt flow? Anybody can answer. What do you think about this shunt flow? So that's a pulse wave Doppler at the PDA. Diastolic, somebody says diastolic runoff. So when we assess the shunt pattern, what we have to assess is how is the flow in systole as well as diastole. Now if you see the ECG below, so from the beginning of the Q wave to the end of the T wave is going to be our systole. From the beginning of the from the end of the T wave till the beginning of the Q wave is going to be diastole. So if you see in systole, the flow is in the opposite direction. That is, it is from the pulmonary artery to the aorta. So this patient, and in the diastole, it is between the aorta and the pulmonary artery. So actually this baby has got a bidirectionally shunting PDA, which is shunting right to left in systole and left to right in diastole. Now my question is, will you ever think of closing this duct? So will you close this duct? So I've got various answers saying that neonatal high PVRI, we have to see other evidence of operability and balloon occlusion and so on. So as I said before, this is predominantly a neonatal talk because that's where we're going to manage medically the PDA. The closure of the PDA in the infancy and in the late is going to be taken in the next lecture. So when you see a bidirectionally shunting PDA, especially if it is right to left in systole and left to right in diastole, this PDA should never be closed because this PDA is decompressing the right ventricle and in the systole, and that is why it is giving rise to a right to left shunt. So that means the PVRI, neonatal PVRI, is higher than your SVRI. which is giving rise to a right to left shunt across the ductal level, and this is actually helping the right ventricle. So we should never close this PDA at this moment. Even if this PDA is big, this PDA is helping the child. Your problem is pulmonary hypertension and not PDA. So you have to treat the pulmonary hypertension, and we'll see the PDA change in the flow with the change in the pulmonary hypertension. So if you see this kind of flow, never ever should you ever think of closing this PDA. What about this? Again, a pulse wave Doppler at the PDA. What do you think about this? What do you think about the flow pattern? Unfortunately, we don't have an ECG over here, but what do you think about this flow pattern in the PDA? So over here, it is predominantly systolic left to right. Yes, as you said, in diastole, there is almost no flow. So it is predominantly left to right. In systole and in diastole, there is absolutely no flow. Almost there is no flow, or maybe there is a little bit of flow reversal. So what does this suggest to you? What do you think is the size of the PDA, and what do you think is the hemodynamics? And will you close this up? Somebody says small pressure in the aorta as well as the pulmonary artery. So there is a difference in the pressure of the aorta and the pulmonary artery in systole, but in diastole they are almost the same, which suggests that this PDA is very big, it is having significant flow, there is significant pulmonary hypertension, and in all probability you will have to close this PDA. What do you think about these two? First, this one. So somebody is saying first is a small PDA. Again, if you see, there is the pressure gradient, it is smaller than the previous one. I do agree, it is smaller than the previous one. There is flow in systole as well as diastole. There is flow in systole as well as in diastole. So this suggests that there is a difference in the aortic and the pulmonary artery, systolic as well as the diastolic flow. Pressure, sorry. However, if you see the diastolic pressure, there is not much difference in the aortic and the pulmonary artery. This again suggests that the PDA is relatively large size, although it is pressure restrictive little bit, but it is not flow restrictive. The flow is quite high across this PDA. Again, in most probability, we'll going to close this PDA. What about the last one? So in the last one, as everybody is saying, yes, it's a very small PDA. You can see a significant difference of the pressure in systole as well as diastole, which is showing sorry, this PDA is a little upside down. There is some mistake in it. All I wanted to show is a restrictive PDA. So this is not a restrictive PDA. It is a right to left shunt, completely right to left shunt, which is shunting right to left in systole as well as diastole. Again, which will suggest a severe pulmonary arterial hypertension. Again, we'll never close this PDA. So shunt volume, as we know, direct calculation is not feasible, so it is commonly estimated using surrogate index. What we see is the left atrial and the left ventricular end diastolic dimension, ratio of the left atrium to the aorta and mitral valve inflow. Also, what we can see is the diastolic flow reversal in the descending aorta, which appears to be a consistent feature of a high volume PDA. So if you take a pulse wave Doppler in the descending aorta, we can see a forward flow in systole and a reversal of flow in diastole. This suggests that there is significant runoff from the PDA into the pulmonary artery, and this PDA is hemodynamically significant. This is one of an important features which you can say that the PDA is hemodynamically significant and large and probably needs closure. So there are certain parameters which are given, and there are various studies which have shown when to close the PDA and when to not to close the PDA. So if the PDA is more than 2 millimeters, it's usually what we see is per millimeter per kg of body weight, rather than seeing an absolute diameter of the PDA. So if the PDA is more than 1.5 millimeters per kg of body weight, it suggests that the PDA is large for the baby and needs to be closed. Also, what we can see is the size of the LA to the aorta using M mode of more than 1.5, ratio of LV end diastolic diameter to the aortic root diameter of more than 2:1, ratio of early and late diastolic inflow velocity across the mitral valve of more than 1, mean LTA antegrade gradient of more than 42, diastolic flow reversal in the systemic artery, and ratio of LV outflow to the superior vena cava flow of more than 4. But however, I would suggest that this is usually theoretical. A rule of thumb we should all remember of more than 1.5. So more than 1.5 millimeter per kg body weight, and aortic root to an LA to aortic root of diameter of more than 1.5, and pan-diastolic flow reversal in the descending aorta are suggestive of a hemodynamically significant PDA, and this PDA needs to be closed. You can use certain biomarkers such as BNP and NT-proBNP. They have significant sensitivity and specificity cutoffs, especially if a BNP of more than or equal to 75 grams has a sensitivity of 93% and specificity of 73%, and N-terminal proBNP of more than 1003. However, again, these are biomarkers. These occur only with the dilatation of the atrial size, and they can occur because of anything. However, a hemodynamically significant PDA, if you suspect on echocardiogram, again I would repeat, a size of more than 1.5 millimeter per kg of body weight, and LA to aorta size of more than 1.5, and pan-diastolic flow reversal across the descending aorta would suggest that the PDA is hemodynamically significant and needs to be closed. Before deciding to close the PDA, there is one more thing that we need to understand, is we should rule out duct-dependent systemic and pulmonary circulations, and once we do that, then only we should recommend closure of the PDA. So two things important. One is rule out a duct-dependent systemic and a pulmonary circulation, and the second is determine whether the PDA is hemodynamically significant. If both these criteria are met, then only we are going to recommend closure of the PDA. And as we said, even after this is done, we have yet to reach a consensus on which PDAs need to be treated, when and how to treat these PDAs. So, a hemodynamically significant PDA in absence of a duct-dependent systemic or a pulmonary circulation can be treated by watchful observation, non-pharmacological approaches or conservative approaches, pharmacological approaches, and mechanical approaches such as surgical ligation or transcatheter ligation. And we'll go through each of these. So conservative management, based on the premise that most PDA would close spontaneously. And what is the conservative management? Is fluid restriction, ventilatory support, optimal use of PEEP and vasopressors, maybe some diuretics and digoxin. Advantages: it avoids the side effects of the pharmacological therapy as well as surgery. Disadvantage is volume overload to the immature lungs and heart, which can be detrimental in the long run. There are not many studies which have studied the conservative approach in detail. Especially, there is no randomized trial in which they have compared a conservative approach versus pharmacological or surgical therapy. What we only have is a before and after study by Kemp et al. It was an observational study. He compared two eras. In era 1, where indomethacin and ligation were used early to close moderate and large PDAs in infants receiving respiratory support, and in era 2, he has used a more conservative approach of fluid restriction and watchful waiting were attempted, and indomethacin and ligation were reserved for those patients with large PDAs who met certain cardiorespiratory distress criteria. So, use of indomethacin decreased significantly from era 1 to era 2, that is 79% to 26%. However, there was no difference in the use of supplemental oxygen and mechanical ventilation. Combined outcome of CLD and death after more than 7 days was higher in era 2 as well as in era 1. And we definitely need more randomized controlled trials which can definitely tell us whether a conservative approach is going to help or not going to help. In pharmacological therapy, we only would treat a patient who is symptomatic. Always remember, I'll tell you the different treatment strategies which can be used in treating, and what are the evidence in each of those. Pharmacotherapy of the PDA closure is based on the role of prostaglandin in ductal constriction. The biochemical mechanisms include effects on cyclooxygenase and peroxidase enzymes. Indomethacin, Ibuprofen, and Acetaminophen are used most frequently. So there are 4 different treatment strategies which are available for pharmacotherapy. One is a prophylactic therapy, one is a treatment of asymptomatic PDA, early targeted treatment of PDA, early and late symptomatic treatment of PDA. So prophylactic therapy, what do you mean by prophylactic therapy is giving all patients who are preterms prophylactically indomethacin without documenting the presence or absence of a PDA. There was a meta-analysis of 19 randomized controlled trials. In all of these, the first dose of indomethacin was received within 24 hours after birth. The rate of the PDA and the particularly rate of ligation of PDA reduced significantly in the prophylactic group. However, we need to treat 20 infants with prophylactic indomethacin to prevent one surgical ligation and treat 4 infants to prevent a later symptomatic PDA. The reduction of any or severe IVH was significantly there in patients who were treated early. For prophylactically, a relative risk of 0.88 and 0.66. However, there is no difference in short-term outcomes like NAC or BPD. Of note, the reduction in the incidence of symptomatic PDA or severe IVH did not translate into improved mortality or long-term neurodevelopmental outcomes, which were assessed at 18 months. So prophylactical treatment of PDA has thus fallen out of favor. Second is a treatment of asymptomatic PD. So this targets high-risk infants, especially with less than 28 weeks with a large PDA on echocardiogram, but not having clinical symptoms or echocardiographic evidence of significant left to right shunt. There was a meta-analysis conducted by Cook et al. In which they found that the reduction in the symptomatic PDA and the diminution of oxygen requirement, especially if you treat a patient with neonate with asymptomatic PDA. However, there was no benefit of mortality, chronic lung disease, IVH, ROP, or length of ventilation. Early targeted therapy is combination of both methods, and there was a double-blind randomized controlled trial by Fluco et al. In which he screened all patients, neonates which are less than 29 weeks, underwent an echo at 3 to 12 hours of life. Those having a large PDA were randomized as having a placebo or IV indomethacin. Infants receiving IV indomethacin, they had approximately 90 patients in this trial, and the trial was stopped at 90 patients as the indomethacin was not available anymore, in the market. And infants receiving early indomethacin had significantly less pulmonary hemorrhage, 2% versus 21%. They had a trend towards lesser periventricular hemorrhage or intraventricular hemorrhage of 4.5 versus 12.5%, and were less likely to receive later an open label treatment of PDA, 20% versus 40%. However, if you see, there was some benefit. However, it did not translate into, so even though there was some benefit, they did not translate into clinically significant benefit. So the requirement of oxygen, chronic lung disease, and ventilation was similar in both the groups. Early and late symptomatic treatment of PDA, what do we mean by this? Is early symptomatic treatment is treat the PDA in between 2 to 5 days when the symptoms of the PDA first occur. Late is treat the patient conservatively first and wait till the second week of life to give a pharmacological therapy if required. So Van Overmeyer et al. Conducted a prospective multi-center trial of early versus late therapy in preterm neonates less than 32 weeks of gestation. The PDA closure rate was higher in the early treatment group. However, there was no difference in the PDA ligation. So even though the PDA closure rate was higher in the early treatment group, both in number of patients requiring PDA ligation was almost the same in both the groups. Early treatment group had more complications. They had lower urine output, higher serum creatinine, required more indomethacin courses. The incidence of major adverse events were very high in the patients who received early symptomatic therapy. So although the PDA was getting closed, it was getting closed at a price, and the price was higher side effects, including death, NEC, perforation, hemorrhage, cystic leukomalacia, which occurred more frequently in the early treatment group versus the late symptomatic treatment group. So that was it short about the different treatment strategies which are currently in use, and the current recommendation is probably to treat the patient conservatively, wait for the first 2 to 5 days, and only give therapy if the patient is not improving or the patient is having other complications of PDA, such as is developing NEC, is developing renal failure, is having unexplained apnea, cannot be managed. In those patients, probably you will advise closure of the PDA, and in that case, it is probably going to be a surgical ligation of PDA as versus medical therapy, because the medical therapy by itself would have those complications. Just in case you reach to the second week of life and still the PDA is large, is hemodynamically significant, and is causing clinical symptoms, that is the time when you decide to close it medically. And in medically, how do you close it? There are 3 basic drugs which are available. One is indomethacin, second is ibuprofen, and third is paracetamol. The first one was indomethacin, and it had shown significant success rate in closure of the PDA. However, after some time, due to some reasons, indomethacin went out of the market, and that's when other drugs such as ibuprofen and paracetamol were tested. So when ibuprofen was compared to indomethacin in a Cochrane database review, which included 20 studies in more than 1,000 neonates, they compared ibuprofen oral or IV with indomethacin oral or IV, and found that the rate in both the drugs, there was no significant difference between the 2 drugs with respect to failure to close the PDA. There was less risk of NEC at any stage with ibuprofen as compared to that of PDA, indomethacin, less risk of oliguria, lower serum creatinine level. So the conclusion was ibuprofen was as effective as indomethacin in closing the duct and reduces the risk of NEC and transient renal insufficiency, which can be seen. Then came acetaminophen, and over here also, if you see, acetaminophen the oral paracetamol was as effective as oral ibuprofen in closure of PDA in both these drugs, in both these trials. The rates were similar for surgical closures, and paracetamol in fact showed decreased incidence of hyperbilirubinemia and GI bleeding and equal efficacy to ibuprofen. So, which drug to use again depends upon unit to unit. Acetaminophen or ibuprofen clearly seem to be better drugs with the similar effects as compared to indomethacin, with lesser side effects as compared to indomethacin. However, we can use the medicines once or maybe twice, and even after 2 doses, if the drug fails to close, having symptomatic, if you have a clinically symptomatic patient with echocardiographic evidence of increased pulmonary blood flow, such as the last shunt, where the LA to the aorta ratio of more than 1.5, having a pan-diastolic flow reversal in the aorta, this patient should definitely go for interventional therapy, either surgical ligation or transcatheter as deemed feasible. To conclude, management of PDA, especially in preterm neonates, is controversial. Small or moderate size PDA, conservative management with high possibility of spontaneous closure. Large PDA, we should always manage conservatively prior to going for medical closure, and even after 2 doses of medical closure, it does not close, and early surgical or device closure should be considered. Thank you.